Hello, everybody. I'm Tim Doherty, an assistant professor at Southern Illinois University, and it's my pleasure that I get to interview Lorna Kahn for the American Society for Peripheral Nerve Synapse newsletter. So thank you, Lorna, for joining with us today. Um, I'm sure that everybody in the audience is very familiar with you and your work, but for those who are not, Lorna is a physical therapist and certified hand therapist at Washington University in St. Louis, and she is a world-renowned hand and peripheral nerve therapist. And she's definitely one of the go-to experts for rehabilitation after nerve injury, repair, and nerve transfer. So, Lorna, if we could just start off with you just introducing yourself and tell me what got you interested in physical therapy and hand therapy and what brought you to St. Louis.
Well, thank you, first of all, for the kind invitation, and I'm thrilled to have this opportunity to speak with you. Um, I got into physical therapy, um, not the typical pathway. Most people who choose physical therapy are athletes, or they were very athletic or sports minded in high school and whatnot. But I didn't come from a sports minded family, but I was always interested in the human body, and I wanted to do something relating to medicine. My sister is a physician, and I knew I didn't want that pathway, and happened to do an internship while I was in high school and was exposed at Rusk in New York to some interesting therapists there. So that cued my interest. And then I chose to come to WashU because at the time, and still today, they're one of the top physical therapy programs in the country. So I figured if I was going to do this, I might as well go there. I didn't know much about the Midwest or St. Louis, coming from New York City. And it was great, but I wanted to leave and move to the West Coast, and did that for a few years, but met my husband and he's from here. And
Okay.
so that's what brought me back.
Nice. So when you came back, how did you meet and become such an integral part of Dr. McKinnon's team?
So I worked in St. Louis for, when I came back, I took a job in an upper extremity clinic, actually under Paul Mansky, and was doing primarily orthopedic related hand injuries, and was there for a little over 10 years. And then I took a small hiatus after my third child was born. And when I came back, I joined Millikan Hand Center, which had been combined with Mansky's center at that time. And I happened one day to be taking walk-ins, and Dr. McKinnon sent over a nerve transfer, which she hadn't been sending them. And I was very nervous because I'd never even heard of a nerve transfer at that time. This was 2006 and had never been exposed, didn't know anything. I gave him a home program, put him on a bus back to Indiana, and then went home and read a lot and started asking Dr. McKinnon a million questions. And I think that my curiosity piqued her interest, and we started talking more and more because her office is right next door to our clinic. And I think she appreciated my interest and invited me to be her liaison in her clinic. And then for the next 18 years, I got to have the privilege of spending 2 days a week in clinic with her. And that has been probably the biggest gift of my life,
Yeah,
professionally and personally.
yeah, very serendipitous that it happened that way too.
Mm-hmm.
Well, I think that Dr. McKinnon would agree that so much of our post-operative results are a credit to you as a therapist, as opposed to even as what we do a finite amount during the surgery. So, from a therapist standpoint, what do you think is the most important thing that we can do in preparation for our cases of nerve injury or nerve transfer to set ourselves up for success?
Well, I think that number one is, from what I've seen, because I've seen patients from not just Dr. McKinnon, but I think that what sets Dr. McKinnon so high above so many is A, her experience, but her level of choosing the right patient. Because as a therapist, it's really hard to, after working with her patients, to maybe see someone who's been not vetted as well, because there are situations where patient shouldn't have a nerve transfer. So that's number one. that the patient was well vetted and clear electrodiagnostics and understanding how far out that recipient muscle has been and the timelines and all of that. So that's number one. And then understanding to the patient for which this is going to go into and making sure that they understand that this isn't just an easy fix, that this is the potential to give them some function, but I never tell a patient and in fact, I clearly tell the patients early on, this is not to make this like it used to be. And so many patients don't hear whatever you tell them, and
Mhm.
this has to be repeated. So if you set the bar a little low or lower, then they appreciate the successes, the small successes that we see, and hope for getting a greater success. So I think without that, they lose motivation, and they aren't always as willing to follow you. I think with nerve injury in general, I think that, the communication, it's such a complex subject. And I think those of us who work in it forget that our language is not language to the general public. And they get so easily lost. And so a lot of times my job is after everyone leaves the room that I try and dumb it down for them. And even the smartest people, if it's not their area of expertise, this is a lot to wrap their head around. And so I think that repetitive nature of educating them is key. And then the other thing is, if we're not talking about nerve transfers, but tendon transfers, I think the biggest thing is to make sure that the patient hasn't had too long without the movement to have developed their whole life based on the substitution patterns they have. Because we've seen some, tendon transfers that in our minds worked great and patients ended up hating them. It hasn't happened very often, but it's because they didn't recognize how much it was going that they had already, after 15 years of getting around without those motions, they had adapted their lives. So those are the things that come to mind.
Is there anything you do in those specific situations for tendon transfers? Do you have them maybe splint in a certain position to make sure that they understand what they're getting?
Yeah, so easy ones would be like an opponent's before an opponent's plasty, to put them in an opposition splint and let them try out the transfer so that they get a sense of what it's going to be like to have their thumb there. And then to explain that, we don't want to stretch it out ever. So there are certain movements that you won't be doing. You won't be doing a downward dog in a normal way, or you won't be transferring or pushing up from that palm. So some are easier to pre-splint than others. The person I'm thinking of had a pin palsy from when she was 16, and at age, 20 years later, she suddenly wanted it fixed, and she had to change how she wrote and how she used utensils and all of that after the tendon transfer. And I think she, in hindsight, we probably would have probably talked her out of it.
Yeah. Well, I spoke to many of my friends who are prior WashU fellows, and they all spoke very highly of you, and that multiple people were impressed, and they told me that you place a lot of value on meeting these patients preoperatively, and that it was quite impressive that the patients would come back excited and informed and had a very clear understanding of what they were expecting the day of surgery and
Mhm.
post-operatively. I think that's certainly sounds like it's a credit to you. Is there anything else that you like to focus on during those visits that you think is particularly beneficial in order to engage the patient that way?
So, well, the preoperatively, I think that, some of the basic things are making sure that they have not only are prepared in terms of what their recipient is and whatnot, but that their joint is ready to receive this transfer. Someone who's had a terrific claw deformity, that's now got a contracture that has to be worked out, or if their shoulder is stuck in internal rotation from being in a sling for a year, they're not going to get external rotation unless so starting to educate them for that. Also, so that the surgeon, lately we've had a few where I recognize that everything's ready to go for surgery, but the patient's not going to be able to position where they need to be in order for the surgeon to access their surgical site. So those basic things of, physically, are they ready? And then I think that making sure they understand how the progression, like one of the things I talk about is that this won't be, explained about kind of like correlating it, or like using the metaphor of a light and a bulb, and a lamp and a cord in relation to a muscle and a nerve. But I tell them when this recovers, it's not going to be like one day you wake up and your elbow bends. It's not a light switch, it's more of a dimmer switch. And so that the light is going to gradually come on very, very, very slowly. And then I teach them about how we test muscles, on a 0 to 5 manual muscle testing scale. And I draw it out, on a graph with, the x-axis being the grades and the y-axis being how much power they have or movement in that arm. And so then I talk about each one. Right now you're a 0, and it may take 5 months before you even have a twitch in that muscle, but that's your first, home run. And then to get to a 2, you'll be able to move the arm a little bit with gravity eliminated. And that may take this many months. And then to bend it against gravity is a 3. And then we may or may not get more. But so then they have very solid information, solid expectations, and they can converse with us in a way that lets us know that they know what they need to be doing as well.
Yeah, well, that's great. Well, as I mentioned, Lorna is very well known for her work with Dr. McKinnon and Dr. Amy Moore for donor activation focused rehabilitation protocols after nerve transfer. So how did you go about developing these protocols? Obviously, you saw a need with an increasing amount of nerve transfers. How did you standardize these and develop them?
Well, basically, it was the sheer volume of nerve. Once I got hooked up with the nerve center, the peripheral nerve center at in Dr. McKinnon's office, and I was working with the likes of McKinnon and Moore and Fox and all these other wonderful surgeons, the volume of nerve transfers just increased exponentially in our clinic. We hadn't really seen them before. And
Mm,
so I have to attribute a lot of the development of the program to the patients themselves. I consider myself a keen observer of symmetry and asymmetry and function of the arm, and observing them and getting to see what's working, what's not, and what happens with this over time. It started to just make sense to me based on the ability to just help these patients start to move their arm. I've had and then as I started to do it, patients would confirm with me what I was thinking. Like I can remember early on a patient who had a double fascicular transfer for elbow flexion, and I was sitting in McKinnon's clinic in the room with him, and nothing was really happening, but I knew something was, and I kind of explained some metaphors for him, and told him, when your hand fists and your wrist moves, that's like the gas pedal. And he's like, oh my God, that's like a light bulb just went off in my head.
mm,
And he was so excited. And so this ability to drive the donor was very clear to me pretty early on. And then from there, it was a matter of, okay, then it's pretty formulaic. We can just adapt this now to, once we understand the basic
mm,
concepts, then of not just what turns on the recipient, but what do we need to prepare for all of this? And then how do we need to, you know, position the patient in the appropriate times? And then things like understanding the relationship between muscle length and
mm.
muscle recovery, and also like Tessa Gordon's work has always been really fascinating to me, and learning about how denervated muscles, can be that are trying to recover early in their recovery are can be reduce their recovery rate can be reduced, and if they are exposed to excessive fatigue. And so I think that's probably one of the biggest pieces of this DAFRA puzzle that was missing, I think, was this understanding that because so many people liken therapy to push hard and make it hurt and more is more. And I'm always the one saying, no, 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 no. That's too much. And we don't want to burn it out in other, it's a way I've kind of put it. But, understanding it on a basic level and then getting the patients to understand this has been really, really important. And so from there, it was then just getting the final push from Dr. Moore and Dr. McKinnon when they edited that, and that edition and asked me to write that chapter. So forced me
So
to sit down and write it.
so how soon after the transfers do you typically see them to work with them for therapy?
So I'm usually in clinic with, and so, I may or may not see them a few days post-op and I'm not really going to intervene at that point because they're pretty overwhelmed with just recovery. But I like them to be seen within the first month. So sometime within the first month. And depending on how many they've had, there's a lot of information to transfer. So I try not to overwhelm them too quick, especially those who I didn't get to see preoperatively. But I want to not that I need to see them a lot, but especially if I hadn't seen them before, I want to make sure there's nothing we don't have to prepare for. I want to make sure that they're positioning properly. I want to kind of set the stage to make everything ideal for that. Because in the last 18 years, I've seen all the things that could potentially go wrong or not, maybe not all of them, but many of them. So now I'm always on the lookout of, yes, you should be in a sling, but no, you shouldn't be in it 24 hours a day. You need to, not impinge that nerve more from being in that sling or, so things like that. There's a lot of patient education that should gradually be brought on. And so starting sometime in the first month is a good idea. And then I also want to make sure that they understand the basics of keeping that swelling down in the area so that nothing scars, because that could potentially add more problems that might interfere with recovery.
Yeah. So I think that myself and certainly most people who do nerve surgery find that the biggest challenge with post-operative recovery is the time that it takes for regeneration. And all of these patients, they seem to be very excited initially, and then they all kind of hit this frustration phase a few months in when it's too early to see function, but they're still early. How do you keep the patients encouraged and engaged during those phases of their recovery?
And that is one of the biggest challenges, I think. And I really encourage, after they've had a few visits in the beginning and you are convinced that they understand the basics of what they should be working on, which isn't a lot. They need to be working their donor and patterning the movement passively on a frequent basis. But other than that, and keeping their range of motion clear and protecting their length. Then it's a matter of just checking in with them monthly. And a lot of patients, once I set that expectation, they really look forward to that monthly visit because they know and then I remind them, we're not expecting anything, but and then I go through the whole process of manual muscle testing them with the donor being rigidly activated. And so this gives them something to look forward to so they understand each month in the process. And then for those who forget, then sometimes I'll get out a tape measure and I'll say, well, let's look at the distance from where they probably put those two nerves together to where that muscle approximately is. And look, that's 6 inches. And each inch is going to take at least a month. And so, look, you're probably here by now, and we wouldn't expect to even begin to turn on that dimmer switch for 3 more months. And so maybe I won't see you for 2 months and then we'll test it. And then even once, but then, the nice thing, one of the things that Dr. McKinnon told me early on was that, ever since you joined me, because I'm a stickler for muscle testing accurately, she's like, well, first of all, you're making my outcomes lower. But but the other thing was that I was finding them sooner. And
Mm,
that's not just exciting for the surgeon, that's huge for the patient to, especially if they understand that a twitch means something, that if I can show them that twitch, which she said, oh, I just would say it hasn't been successful until it actually could bend against gravity. Well, you've
mm,
missed many months of many home runs. So having them get to see, and I have them palpate, and I show them what turns that on, and I show them when they make a fist that they can feel it. Having them own that is really, really exciting. And they really look forward to the monthly visits so that we can say, okay, this is what's happening. And then those early from, the twitch to 2 or 3, I'm measuring them. The DFT is just the easiest to talk about because it's the easiest to picture, but I'll put them in a gravity lesson plane so their arm is up on a high table,
mhm,
so that the elbow flexors bend in a gravity limited or lesson plane on a slick surface or a skate. And I'll measure goniometrically while they're activating their donor how much flexion, and they may only move 15 degrees the first time we do this, but then they come back a month later and they can do it, 40 degrees. And so numbers mean things. It's not, they understand it's not going to be functional for a while, but giving them so that they know, oh, it was this much then, and now this is, so I am improving. And so you have to prove to them that things are happening.
yeah.
Because a lot of times, that was the other thing that was so exciting about starting to nerve transfers as a therapist, is that we often get to see these things before the surgeon or even the patient knows. And
Hmm.
I would have patients crying and their mothers crying because they have a twitch, and that was just so rewarding to be able to like let them know, yes, this is coming back. You're going to be able to bend your elbow again. So it's a self-motivating process. It's obviously frustrating when you don't see a result,
Hmm.
um, and then that becomes a challenge. I have to share, if I may,
Yeah.
patient just recently, my most recent excitement with a patient was that a patient who came to me 7 months post upper trunk injury with a brain injury, who was seen out of state, came back to live closer to home, had never had 3 major transfers and never had any rehab, and and he was seeing a hand surgeon for he had issues downstream in his hand that were sort of related, but I won't get into that. But his big things were a DFT, a spinal accessory to surface gap, and a triceps axillary. And just this week, he's now 13 months out, and I really pushed hard to get him starting to protect the length, because his arm was completely stretched out because it had been hanging at his side for months, which also made his chronic neuropathic pain worse. So we got all of that, and finally, for the first time at 13 months, I was able to bring him up into full elbow flexion, had him fist and bend his wrist in really hard, and he was able to hold it against gravity, which he didn't know he had. And so that was huge. I mean, he had been up till then moving it 30 degrees in a gravity lesson plane. So
Hmm.
that was really exciting. So it's fun after all these years to still have those moments.
Yeah. Well, your patients are definitely very lucky to have you treat them, considering your wealth of knowledge. Unfortunately, a lot of therapists aren't aware of nerve transfers still, and have a difficult time treating them because they're not aware of these protocols. And similarly, in that post-operative period, we'll have outside therapists reach out to us and say, well, this patient isn't progressing, so and let's request to end therapy. And
Mhm.
similarly to that last question, what tips do you have to help keep therapists engaged, or what more can we do um, so that they're aware of? I usually will print out the protocols and send them, but still they will see a patient not progressing and want to um, end therapy earlier, when now's when the patient really needs it.
Right. So I see this a lot because a lot of our patients come from out of town, and they come in every 3 months, and I ask them specifically what they're doing. And so my 2 biggest pet peeves, one is that they've been in therapy 3 times a week for the last 3 months. And I'm like, well, what were they doing? Because there's nothing to work with. So please don't waste my insurance visits.
Mhm.
And I often am careful to check Dr. McKinnon's plan of cares that come back for signatures from out of town people just to make sure that those visits aren't being wasted. Because when they finally need them, they may not be there.
Mhm.
And then the other thing is then you suggest that they only see them once a month. So write their order to only follow them once a month until activation and some movement is noted, so that they start to learn how, and then during that one monthly visit to be checking for what happens when they activate that donor and can they palpate or anything in the recipient. And then the patterning. So they should be teaching the patient. We want to expand their cortical plasticity by, having them co-contract, and they're not going to contract in the recipient muscle, but for the brain to be doing an activity where they're contracting the donor and bilaterally, but passively for the involved side, moving the limb in whatever direction it is. And they also should be picking up for, any substitution patterns and making sure that we're not letting those override everything. And that's especially true in some of the smaller transfers of the hand, like AAN to ulnar. That can be really tricky.
Mhm.
And that's can take a really long time. And so my biggest not trick, but advice for that is that one of the biggest mistakes I see is someone who's had a claw hand for a long time, their extrinsics are so um, overused in substituting that substitution pattern becomes really hard to break. And so it's really imperative that they're in an anti-claw splint during the day, and so that they can't let that volar MCP joint become overstretched.
Mhm.
And also then that they can have a better chance of isolating the motion. And the other thing in those cases would be, I see patients try too hard, and it sounds counterintuitive, but for those little intrinsic muscles, I have them try it on their other hand. I'm like, look how little effort you put into that. If you put too much effort for, something that has a quarter of the power, you're just going to turn on your extrinsics. So
Mhm.
we talk about just barely moving it, and that's why the assisted movements are so important early on as well. So
Yeah.
I could talk for an hour about that.
Well, we've talked about multiple different transfers, and you've undoubtedly seen them all. What, in your opinion, which transfers do well, better than others? Which are there any subsets of patients that we should be avoiding nerve transfers in? Should there be an age limit? Have you noticed any patterns in that regard?
Um, so in terms of the best transfers, to the first question, um, from my experience, the best result I've ever seen was from a young DFT for elbow flexion.
Yeah.
Um, I think clearly, there was an article years ago from Malisi that talked about the importance of having a pre-existing kind of cortical bridge so that it's a pre-existing synergistic movement. And one of my talks, I talk about how, like, I have a copy of one of our MA's ultrasound from when she was pregnant, and there was the baby fisting and pulling their hand to their mouth, bending their elbow. So it's clearly that's that homunculus has some cortical bridging for there, and that makes that much easier to recover. Anyway, so I think that's one example of the potential for a really strong recovery, and I think that synergistic pattern makes it very easy. It's the ones where it's a non-synergistic movement that are the most challenging for the therapist, and challenging for the patient. And you really require a lot of creativity to figure out how you're going to repetitively do a motion that doesn't necessarily go together. And so what comes to mind, I know this is a favorite for surgeons because apparently it's relatively simple in terms of location, is the thoracodorsal to long thoracic.
Hmm.
And that's because the thoracodorsal is for the lat. That lat does shoulder extension and internal rotation, whereas the serratus, that is the recipient, is helping to guide the scapula to allow for flexion. So almost antagonistic. And so we have to do these co-contractions and that we do get tone and function, but it's a difficult one for the brain to
Mhm.
do and for the patient to learn.
Yeah.
Um, Subsets of patients that are ideal or not. I think that tendon or nerve transfers in patients who have like morbid obesity, if the limb is really hard, heavy. I've seen a few failures. I don't see many failures, I have to admit, from Dr. McKinnon's office, but the few that stick out, there was a tendon transfer in a woman who just had too much weight in that arm to be successful. And I think obviously the young, healthy, normal weight people have an advantage. I think there's some people who have a greater body kinesthetic awareness, and that makes them being more in tune with their body and how it moves helps them a little bit. Not that
Mm.
we shouldn't do surgery on those that don't have that, because there are plenty of nerve transfers where it's just dumb luck. They don't do anything, they skip therapy, and the nerve transfer is so synergistic that it comes back. And an example of that would be the supinator to pin,
Mhm.
which when we do that with the quads, I don't even train for it because I know it's going to come back sooner than something like the brachialis to AIN. And I don't want it to overpower and become an extension hand before I get the fist.
Mhm.
So that tends to happen without anyone trying. Um, I don't know if I answered the whole question.
Yeah.
Yeah.
Yeah. Well, for those who are viewing who are doing these surgeries but are not familiar or don't have a therapist like you, how do you recommend implementing these and communicating these protocols to other therapists? And are there any for those therapists and for those of us who are doing them frequently, are there any courses or online training modules that you're aware of that we can direct our therapists to for further training on these?
So this is why we wrote the book.
Yes.
And we're hoping that this helps a lot because we're trying to make it pretty user friendly. It won't be all inclusive, but it will. I think we're covering 21 different nerve transfers in the book. And um, so I think that resource is long overdue. I meant to try and start this on my own years ago during COVID, and just it's too big a project to have done alone. And so I'm grateful that I was invited to this team with Macy Stoner and Christy to do this. So I think that you can get the framework from the DAFRA article that I published in 2016, but a lot of the tricks and things like that, Macy and I published just last year in Journal of Hand Surgery on the key components and talking about things like the importance of length and the importance of avoiding fatigue and those other very important concepts that you could be doing everything else right, but not understanding that. And I think that those are really would be helpful. I also, have been invited often to many of the places that Dr. McKinnon's fellows end up, and have given talks at different sites. And so, once the book is over, I'm hoping to be able to do more of that. Last year, I was invited by the Michigan Hand Society, Hand Therapy Society meeting to host a day-and-a-half course on plexus.
Mhm.
Elspeth Hill from Yale joined me and gave a few of the talks, but we had a good time doing it, and we've thought about trying to offer that as for other sites around the country for therapists to learn more about nerves just in general, not just nerve transfers, although that's part of it, but kind of a good comprehensive day-and-a-half course. A lot of information, but
Yes.
So those are some opportunities that, going to things like the ASHT meetings and some of these others, there's usually, I'm not the only one talking about it anymore. So
Hmm.
my hope is that, the book will get more people doing it, so that then we also need people to start really researching outcomes and
Hmm.
challenging my ideas. I'm open to that. I figured out how to make my patients get through this and get something out of it, but I'm hoping others will find more and start to publish about it.
Yeah, well, great. Well, as we wrap up here in the last few minutes, what, with the many accomplishments that you have had, what are the ones that you are most proud of?
So when it comes to nerves in general, if we're not just talking about nerve transfers, because the clinics now, I'm treating a variety. I mean, the things I'm most proud of is, and I don't know if pride is the right word, but I'm most grateful for my almost 20 years of collaboration with and friendship with Susan McKinnon and Ida Fox and all of the wonderful surgeons that I get to work with. So I feel immensely blessed and grateful for being part of a team, because in medicine, I think that we've shown that that's like a really a great thing for patients, and it's also a great way to motivate each of us to learn differently from each other. So I feel I'm very curious and I love figuring out problems. So I feel like that my diagnostic skills are something I'm very proud of in terms of trying to figure out what's going on with the patient and what needs to be done. But in terms of specific patients, there's a couple. There's one who was a child that came to us, who had been told by a psychiatrist that she had a clenched fist and that it was all in her head, and that she was sent to our clinic to have a therapist forcefully open her hand. And I heard the patient screaming and asked to see her the next time. And long and short of it is she had a median nerve compression from a faulty blood draw. And
Hmm.
I was able to get Dr. McKinnon involved pretty quickly. It took a few months for the patient's parents and for the other doctors who were adamant that it was all in her head still to allow Dr. McKinnon to intervene, because the effects of the nerve compression had really altered the child's, not only her function, but her entire psyche. She became really introverted and it changed her personality. And then, flash forward a year. The day after surgery, McKinnon sent me to her hospital room. I was so nervous because I felt so responsible for whatever happened. And she was patting a balloon, and she hadn't used that hand in months. And then her mom sent me videos of her winning a golf tournament at age 10, So
Oh,
those kinds of things, there's no price tag for those. And
hmm.
so I think that, and then the other would be like patients that come to us that others had given up on, and we've been able to help them. I think, that's what I do this all for. So
Yeah, well, that's incredible. I can't imagine how many patients have benefited from your work, and not even just that ones you've treated, but elsewhere as well, from knowing your protocols and your work. So, well, I think we definitely all look forward to the textbook, and I want to thank you for sharing your expertise today. And all of us will definitely continue to benefit from your work. So,
thank you
on
so
behalf
much.
of ASPN and the Synapse editorial team, we definitely appreciate you taking the time today to speak with us, and it's really been a pleasure.
Great. Nice to talk to you. Have a
Uh,
great day.
Thank you, you too.
Take care.